When you are preparing the child for the procedure, then remember the psychological preparation. Be age specific, so use age specific guidelines. Remember that those guidelines will be based on developmental characteristics. You want to establish trust, have a parental presence and support, provide an explanation that is focused to their developmental level, and then physically prepare them for the procedures, just like you would physically prepare an adult. With pharmacology, safety is really our key focus. It's one of the most important responsibilities that we have as nurses. Nurses are legally liable for medication administration, and sometimes the guidelines for pediatric population, those guidelines aren't clearly defined. So when you are thinking about safety, the safe use of pediatric medications, remember that the pediatric client has an immature physiologic process, so young children may have a greater decreased ability, or they have a decreased ability of handling drugs by the body, especially the metabolic and endocrine processes. Be cognizant of the body surface area. When you're comparing the body surface area of an infant or a young child, it is proportionately greater than that of an older child or adult. So we see increased risk for insensible water loss through the skin. They also have a proportionally increased surface area in the GI tract for fluid loss. So when you're thinking about that, just remember to double check, triple check, and ensure that you are administering the proper medications. When medicating children, we did show the video in class. There are review questions at the end of this presentation, so I would take a look at those review questions and then review your nursing interventions that are associated with medication administration. So the video talked about factors that can influence the therapeutic response. So really, when you're thinking about that, oral is obviously the best because it is the least invasive. However, gastric and enzymatic enzymes are going to influence gastric acidity. Their gastric motility is hard to predict. So some meds need certain enzymes to be absorbed. So we need to think about where they are at as far as growth and development go. With topical administration, they do have a thinner epithelium, so they will have an increased absorption rate. Especially be aware of this when you are thinking about giving steroid ointments. The IM injection sites, those muscles are really relatively small, so take a minute to review your IM injection sites. They were discussed on the video, so do take a look at that. And then IV administration is really the most reliable, but not all IV medications are specific to the pediatric population. So we do need to be conscious of what the dosages are that we are administering. And then if you are thinking about IV sites, is it peripheral or is it a central line? So being aware of those types of things with the absorption rate. Remember to review your 6 rights. They're listed out on this slide. We have talked about them from Introduction of Nursing. So remember your 6 rights. And when they talk about the right patient, remember to look at your armbands and not always trust your child or the pediatric client. They may, as the video said, deny who they are so they don't have to take a medicine or have to have a shot. And so making sure that you are getting that right patient identified. Reviewing the administration procedures for medication administration. This, I'm just going to click through these real quickly. If we are administering oral medications, remember that it's best to use a syringe if it's going to be less than 5 ml, so that we have better accurate measurement. We can use a nipple inside of, or a syringe inside of a nipple, or else placing that syringe in that outer pocket of the child's mouth. Rectal is really not preferred because when you think about the rectal administration, children don't want to be violated or feel violated. Erratic absorption, especially if the rectum is full of stool, it's very stressful, but sometimes it may be necessary. So just, always kind of keep that in the back of your head. Subcutaneous, obviously that's going to be that tissue just below the skin. The needle sizes that we would like to see, 1/2 inch to 5/8 inch, and usually with subcutaneous injections, the volume is going to be 0.5 ml or less. And then remember, when you are administering the sub-Q injections, that you are going in at a 45-degree angle. And then there's just a couple of different photos for you to look at when you are administering sub-Q medications, as well as the sub-Q sites. The video spent a great deal of time talking about IM. Really, when we are looking at IM medications, this should kind of be our last resort because it's painful. So when you're thinking about IM injections, one-time dosing is really rule of thumb for medication via the IM route. If someone needs a couple of days of antibiotics, then really if you can get an IV site, your IV route is going to be much more atraumatic, provide less painful routes of administration for these children. Vaccines, obviously we're going to be giving vaccines via the IM site. Choosing the site is going to be very dependent on age and how well developed that muscle is. Sites we should not use in children less than 2 years of age are going to be your deltoid muscle, as well as either of the buttock sites, so your ventral gluteal or dorsal gluteal. Needle sizes really are listed out up here. Obviously, you're going to go with the shorter needle for younger ages. Typically, we want to see a 21 to 25 gauge. Really, a 21 is getting kind of big, so if you can use those smaller gauges, obviously that's going to be better. Typically, rule of thumb for volume is if you have someone less than a year, then we want to keep the IM administration under 1 ml. This is just photos of different sites, and they were discussed at length in the video, so I'm not going to spend a great deal of time discussing them. As far as intravenous routes, you as beginning nurses probably won't have the opportunity to attempt IV or starting IVs on the pediatric patient. When you are thinking especially of your infant, veins can be difficult to locate just due to an abundance of fatty tissue or the depth of the veins. We are seeing more frequent use of intravenous routes simply because it is going to provide an easier way for atraumatic care. We should be assessing sites at least hourly. When you are thinking about using a scalp site, the thing to remember about scalp veins is that scalp veins have no valves, so they can actually be placed in either direction. And when you are using a scalp vein, we can use those up to 9 months. We do want to be giving administration of drugs IV very slowly. Watch for adverse reactions. Always have a pediatric IV on a pump. Using a micro drip or the 60 drops per ml. We typically do not see bags over 250 milliliters if the child is less than 2 years old, and then you can use up to 500 ml bags. So we're not going to go hang 1000 cc or 1000 ml bags on kids because we know that pumps can malfunction and we don't want to cause circulatory overload. The needle gauges or the over-the-needle cannulas, what we'll be looking at are the 22 or 24 gauges. When we're giving IV boluses or intermittent, it's we always want to double check the dose, make sure it's the right dose, that it's the right route, that it's compatible. And then if you have questions, it's really important to call the pharmacy and discuss your questions with them. When you are using ophthalmic, it's an alternative to oral antibiotics if the child has conjunctivitis or something of the eyes. An alternate method to teach parents is that have the child close their eyes and then instilling those drops on the inner canthus, and then tell the child to open their eyes just as it was shown in the video. When you are looking at ODIC administration, remember that when they are older, you need to pull the ear up and back, and when they're younger, you need to pull the lower part down. So I would take a look at that and make sure that you have a solid understanding of med administration. I'm going to end with this presentation here. I will finish with cerebral palsy, failure to thrive, and Down syndrome on the final voiceover presentation. If you have questions, please don't hesitate to send me an email or stop by my office. My office hours are posted on my door. Thanks so much.